Welcome back, everyone. I am super excited to get to introduce my co-chair, Dr. Shada Alami, who is giving our next talk on management of confusing results. She is an internist in Seattle and is affiliated with the Seattle Healthcare System Puget Sound Hospital. She received her medical degree from University of Washington School of Medicine, and she has been in practice for several years, about 6 to 10. All right, Shada, take it away.
Thanks so much. Like Mathany said, my name's Shada. I'm a physician at the Seattle VA, and I'm going to be giving you a talk on the management of confusing results. So I have no financial or really other conflicts of interest. I'm a primary care doctor, and so that's the lens through which I present to you this information. And my intellectual conflict, or I guess motivation, is just I'm motivated by things that I find confusing. And I found that in my first several years of practice, I was confused about how to manage or how to follow up certain abnormal lab results. There was a gap in my knowledge from residency. So that's what I'm going to be presenting to you today. So my objectives by the end of this talk, you should be able to utilize a structured approach to the evaluation of macrocytosis, understand the SPEP, and understand what differentiates a low-risk MGUS, or monoclonal gammopathy of undetermined significance. And then I will talk briefly about the interpretation of a positive rheumatoid factor and the importance of interpreting that in an appropriate clinical context. So we'll start with a case. So the first case, DS is a 78-year-old who presents for his annual visit. He is generally well. He's got well-controlled hypertension and hyperlipidemia. Otherwise, he's doing great. He takes amlodipine 10 milligrams daily and atorvastatin 20 milligrams daily. And he really has no concern. He just came in for his annual and he wants to get annual labs drawn. So against your better judgment, you order a screening CBC, which shows the following. I'll let you marinate on that for a little while. And then I'm going to just highlight what we're going to talk about today, which is the high MCV. So a couple questions. Number one, what is going on? And what do you do next as the primary care physician? So I want you to just pause in your moment, think about when you see this lab, which was an elevated MCV, what do you do? So this is macrocytosis, and just to clarify and define, macrocytosis is a morphologic term. So it doesn't reflect a specific pathology or a specific disease state. It's a marker that can be caused by multiple disease states. And so it's defined by having a higher than normal MCV. Usually the upper limit of normal on MCV is 98, but it can differ by different labs. And this is measured in femtoliters. Sometimes macrocytosis is also diagnosed by peripheral smear when a pathologist is looking at the smear and they notice that the red blood cells are larger than should be expected. So when we see macrocytosis, I think we need to ask ourselves three big questions to start. Number one, is it real? So what I mean by this, is it real? Sometimes we can see macrocytosis reflected on the MCV, reflected on the CBC as an enlarged MCV, but it doesn't necessarily mean the red blood cell size is high. So sometimes this can happen when red blood cells get clumped. They stick together and they seem bigger, right? If there's not manual evaluation of this smear, but rather a machine is measuring size and there's multiple red blood cells together, they're going to measure them as larger. This can also happen with cold agglutinin disease. And then in hyperglycemia, especially significant hyperglycemia, like blood sugars in the 600s, for example, you'll get osmotic swelling of the red blood cells, and that can cause a falsely high MCV. So really, if you suspect that maybe this doesn't make sense to you and is unclear, you can repeat a CBC with a diff and a peripheral smear to really make sure that there isn't RBC clumping. Try to repeat it without significant hyperglycemia. And then in the setting of suspected cold agglutinations, which is less common for sure, you could try to warm the sample before testing. So Really, most of the time in clinical practice, is it real? I would suggest a peripheral smear, a diff, and then making sure somebody is relatively euglycemic. And once we know if it's real, so say in the situation we know this is real, true macrocytosis, the next question we need to ask ourselves is, does this patient need a hematologist? And perhaps at some point they will need a hematologist, but in the short term, you really want to involve hematology early if there's significant neutropenia, meaning an absolute neutrophil count less than 1,000, or thrombocytopenia. So if other cell lines are involved, I would involve a hematologist. If this is just macrocytosis and there's no anemia, or macrocytosis with some anemia, I think this still remains in the domain of the primary care doctor, at least for now. Okay, so we've identified that this is real, and we do not believe this patient needs a hematologist right now because there's no neutropenia or thrombocytopenia.
100 West Clinic Lobby.
So then we're left with the big question of why is this happening? And I think that's the perennial question of the internist. Why? It really makes a good internist, constantly asking why. So seeing someone has macrocytosis, why is it happening? And I would say most often there are three, I'd say most likely causes of macrocytosis. Number one being alcohol, hemolysis, and then B12 or folate deficiency. So these are the top three things that I really consider when I see macrocytosis. And I'm going to talk a little bit more about each of these. So alcohol, I think it can't really be overstated how often patients underreport the use of alcohol. And I would say in several studies, 11 to 37% of macrocytosis is thought to be related just to alcohol. And this can occur without anemia, and often it develops before anemia. So we know that alcohol is directly toxic to the marrow and can cause changes in the red blood cell membrane. And so often we will see macrocytosis developing with alcohol use before anemia. The amount of alcohol that's thought to be sufficient to cause macrocytosis is about 80 grams per day, which is the equivalent of a bottle of wine. So many of us have patients in our practice that drink a bottle of wine a day. We know that's not a healthy amount of alcohol to consume, but they may have no social consequences to their alcohol use, and they may have unhealthy alcohol use without a frank alcohol use disorder that is causing this macrocytosis on their CBC. Okay. Next, hemolysis. So clues to hemolysis on the CBC, any kind of anemia will cause a reticulocytosis if there's enough iron and B12 and folate nutritionally to serve as the precursor for new cells. But in hemolysis, you really have a robust reticulocytosis. So if you were to get a reticulocyte count, you would see it was significantly elevated, provided they have the nutrients they need to create cells. A clue to this on this smear might be a high RDW. If you remember, reticulocytes are large cells. And so if you have some small cells or differently shaped cells from hemolysis and then large reticulocytes, that'll cause a wide range in the size of cells, leading to a high RDW. And then if you're getting a peripheral smear, you'll often see spherocytes on smear, which is another clue that there's hemolysis occurring. And then another common cause of macrocytosis would be B12 or folate deficiency. This is more common when the macrocytosis is severe. So when the MCV is greater than 110 or even like greater than 115, it's much more likely to be related to a B12 or a folate deficiency because this causes a megaloblastic anemia. If somebody obviously is not getting B12 in their diet because they're vegan, recall B12 is an animal product nutritionally. Or if they have symptoms of a B12 deficiency, like neuropathy, that's when you would consider that the macrocytosis would be more likely to be related to this nutrient deficiency. So in macrocytosis, I talked about the top 3 causes, but there's other reasons for this as well. Medications, which I'll speak to next. There are many common medications in primary care that can cause macrocytosis through different mechanisms. Some of them known, some of them unknown. Maybe they cause nutrient deficiencies. Maybe they are directly toxic to, or just change the shape of the red blood cells. Thyroid disease, in particular, hypothyroidism, is thought to cause macrocytosis, as do other vitamin deficiencies like copper, which we should be particularly on the lookout for in patients that have had gastric bypass surgery. The other patients that are at risk for copper deficiency are patients that take very high levels of zinc supplements. High levels of zinc supplementation can lead to copper deficiency, and then through that mechanism cause macrocytosis. And then patients with HIV. So speaking to medications, there's a very long list of medications that can cause drug-induced macrocytosis. And so if you're seeing a patient with macrocytosis and you don't really know why they have it, I would suggest just looking it up on UpToDate, looking at the long list, but just to keep in your brain, really common medications I see that are implicated in macrocytosis would be proton pump inhibitors like omeprazole, allopurinol, several antibiotics, metformin, thought to be through causing B12 deficiency, can also lead to drug-induced macrocytosis. Just going to pause, folks, to view this list. And again, there's an extensive list of medications. I just picked out some that I thought we were more likely to see in primary care settings. Okay, so macrocytosis. So I talked about multiple different causes, and when you take that into practice, what do you do with that? So I'll just tell you my approach to macrocytosis, and you can take it with you if you want, which is I ask everybody about alcohol, and I think it's another opportunity to ask people about alcohol, right? We should be doing this in the primary care setting because we know that screening and brief intervention for alcohol use reduces alcohol use amongst people with alcohol use disorder and with people with unhealthy alcohol. Meaning, well, Dr. Hagen talked about telling people to diet and exercise to lose weight does not make people lose weight. Suggesting to people at their doctor that, as their doctor, that the amount of alcohol they're drinking is unhealthy and negatively impacting their health is actually an evidence-based approach to get people to drink less alcohol. So I ask everybody about alcohol and I make recommendations for healthy amounts of alcohol to drink, which really is ideally no alcohol, but keeping within healthy limits, which would be less than 14 drinks per week per men and less than 7 drinks per week per women or people over 65. So number one, I ask everybody about alcohol. That's honestly where I start my conversation because in my practice, the majority of people with macrocytosis is related to unhealthy alcohol use. And then I get some more labs. So I think a manual a diff and a peripheral smear are important, both for making sure this is real, looking for spherocytes. I get a reticulocyte count. I get a complete metabolic panel. I don't always get a haptoglobin and an LDH in my practice. I think if I'm suspicious for hemolysis, if there's an anemia, I don't really know why it's there. If that RDW is really high, if there's a really high reticulocyte count, then I get an LDH. I always get a B12 folate, TSH, and HIV as far as follow-up labs. And I have not been getting a copper in my practice, though I think after researching for this talk, I might start to incorporate copper levels more frequently and definitely in folks with a history of gastric bypass surgery or folks that are taking a lot of supplements, particularly zinc. So I ask everyone about alcohol. I get some more labs. I look at their med list and I see, oh, can I be explained by their PPI? And then if I do or do not find a reason, if there's not a significant anemia or cytopenia, I just monitor them. And you can monitor a CBC every 6 to 12 months for the development of cytopenias. Now, the question is, in these folks with macrocytosis, which we don't really have a reason for, especially older adults like the gentleman in this case who's 78, there's always this question is this MDS? Is this a harbinger of badness to come? Are they going to develop MDS, myelodysplastic syndrome? And the Reality is maybe they are, but there's no data to support that early diagnosis of MDS improves people's morbidity or mortality from MDS or leukemia. And so I personally do not chase it down. I just continue to monitor their cell counts and see if a cytopenia develops. Okay, so that handles the first objective, which is developing a framework for macrocytosis with or without anemia. Now I'm going to get into the second case, which is really the meat of this talk. So MM is a 70-year-old man who presents for follow-up. Your colleague saw him in clinic last month for evaluation of anemia, and he received a letter in the mail after his visit noting, quote, abnormal SPEP results. He does not know what this means, but he has done some reading online and is worried he has blood cancer. He looks to you, his primary care doctor, to explain. So this is my face when I get an abnormal SPEP, especially before this talk. And I have to say, SPEP is something that has eluded me for a long time. I organize the academic conferences at my site, and I have asked several people to come give talks on SPEPs because it confuses me. And then I'm still confused. And then I get an abnormal SPEP result, and I feel like I don't know what to do. I don't even really know what these terms mean. I've read about it a lot. I don't know. For some reason, this is just a topic that was like really hard for me to figure out. And so I'm going to attempt to explain this in basic terms. And so forgive me if you're beyond this, but this is kind of what I needed to break it down to understand an abnormal SPEP. So first, what is an SPEP? An SPEP is serum protein electrophoresis, and that's where it gets the acronym SPEP. So my first question is like, okay, proteins, I know what proteins are, but what proteins are involved? I know about albumins, that's a protein I know about. And I see on my CMP this thing called globulin, and I don't really know what globulin is. Like, I know it's a protein, but what is globulin? So that's something I had to figure out. And then what is electrophoresis? So taking you back to high school biology class, electrophoresis. So electrophoresis is a technique basically in science and biology. And typically you start with this casting tray and then you pour agar solution, which again, bringing you back, agar is like a seaweed based powder that makes this gel. And then you can have wells in the gel where you load different proteins in. And in electrophoresis, you basically have an anode and a cathode, so a positive and a negative charge on either end of the gel, and then you hook it up to a power supply. And that allows you to use electricity to make proteins move through the gel, and they're separated based on charge and size. So when we electrophorese proteins, we're basically separating out a clump of proteins into its respective components based on the size of the proteins. So an SPEP is where a pathologist looks at these electrophoresis results and through a sort of semi-quantitative test, looks at the different amounts of the proteins that separate out. So you can see along the gel, there's a really dark band on the left for albumin because there's a lot of protein in our body for albumin. It's one of the main proteins in our body. And then there's some other protein clumps. There's this alpha-1 clump, alpha-2 clump, beta clump, gamma clump. Those are different proteins, right? Like different sized proteins. So they moved a different distance across the gel and separate it out. And the pathologists have to look at these and interpret them and to say like how much of each type of protein is in this serum sample. If you're like, I'm not following, I've lost you, I would highly recommend the Curbsiders Internal Medicine podcast on SPEPs. I listened to this multiple times and read the transcript multiple times to try to figure this out. And they tell people to take your right hand and kind of make a shaka sign with your hand, the Hawaiian hang loose symbol, to kind of remember what the normal distribution of proteins in an SPEP should look like. So if your pinky is the albumin, that's the biggest spike. You have the most amount of albumin protein in your body. And then the alpha, gamma, and beta are your fourth, third, and second finger. And then the gamma is your thumb. So the gamma is typically the second most amount of protein in your body. Now, when we talk about monoclonal gammopathies, so monoclonal, right, means there's one clone. So like a plasma cell has cloned, so is making a lot of one type of protein. The reason it's called a monoclonal gammopathy is because it's making one type of protein that's typically in the gamma region. Okay, so I'm gonna pause there. So it'd be in like the thumb region. So if I go back to this SPEP image, in a monoclonal gammopathy, the gamma region is bigger than normal because there's a clone cell that's making a lot more protein than we would expect that's in that gamma region. Okay, and then going back, so what are these proteins? So I know that the the big spike is albumin, and I know about albumin, right? Albumin is an important nutritional protein in the body. But what is my ring finger, middle finger, second finger, thumb? What do those represent? And so they're different proteins in the body. So in the alpha spike, that's alpha-1 antitrypsin, thyroid binding globulin is there. In the alpha-2 spike, that's ceruloplasmin, haptoglobin. The beta spike is transferrin and beta lipoprotein, right? Other proteins in the body that we know are important for the body function. The gamma spike is mostly immunoglobulins. So, and I'll talk a little bit more about immunoglobulins. So what is contained in that gamma spike is mostly immunoglobulins. And then all of these proteins that are not albumin are reported on the CMP under globulin. So when you have a monoclonal gammopathy or a spike in the gamma region, sometimes on CMP, you will see a higher than normal globulin level and an abnormal albumin to globulin ratio because there's so much more immunoglobulin being produced in that gamma region of the SPEP. Okay. So what is an immunoglobulin? Like we have to break down these terms. Immunoglobulin, remember, is the fancy term for antibody. And then what is an antibody? So we know antibodies help our body fight infections, but structurally, antibodies have heavy chains. And that can be, we think about like the IgG type of antibodies, IgA, we have IgM, IgG, and IgE. And they're typically paired with a light chain, like a kappa or a lambda. And this is going to be more important when we discuss testing for free light chains. So typically an antibody has this heavy chain and this light chain paired to it. So usually it's an IgG kappa. So it's an IgG heavy chain paired with a kappa light chain. Or maybe it's an IgA lambda. That is typically the notation for antibodies, kind of which heavy chain, which light chain there is. And so there's 10 usual combinations of antibodies in this way. Okay. So I hope I've explained to you what an SPEP is. An SPEP is where we take serum proteins, we run them through electrophoresis to try to separate them by size and then figure out what are the different proteins in someone's serum. And does that pattern match the normal pattern that we expect, where we have a majority of albumin and then some globulin, which is made up of different things. And within the globulin, immunoglobulins, and that gamma spike is typically the most prevalent protein. So an SPEP is a quantitative test that answers, is there an M spike? So an M spike is a monoclonal spike or a spike in that SPEP caused by a single plasma cell clone that we don't expect. So that bigger than normal spike in the gamma region, and I would say it's not always in the gamma region, but it's mostly in the gamma region. So I think for simplification, we can just think about it in the gamma region. So the SPEP answers, is there an M spike? How much protein is there? Is this a normal pattern? So often when you'll see the SPEP results come back, if it's normal, it'll show the amounts of protein in each of those categories: albumin, alpha 1, alpha 2, beta, and gamma, and then it'll say something at the bottom like normal ratio. If it's abnormal, it'll say there's an M spike. In what region? So usually it's going to be an M spike in the gamma region, and then it'll tell you how much protein is there. Immunofixation is important because it answers, what is the M spike made of? So I showed you that diagram of the immunoglobulins or the antibodies, and the M spike can be made of IgG, IgA, IgM, IgD, which one, and what type of antibody is sort of being cloned and what light chain. So in most labs, the immunofixation is reflexive. So where I work at the VA, if you order an SPEP, if the SPEP is normal, you're done. If the SPEP is abnormal, the lab will reflexively send an immunofixation to tell you what the protein is in that M spike. Okay. And what about free light chains? So again, I showed you that diagram of the antibody. Why do we need to send a free light chain level? So in our lab, the free light chains is a separate test. And the reason why we need to send free light chains is sometimes the M spike isn't a heavy chain and a free light chain, because in monoclonal processes, this is abnormal physiology, right? Sometimes it's not cloning the IgG. Sometimes it's like just a bunch of light chains together, and it's an abnormal antibody that doesn't make sense. About 30% of multiple myeloma is thought to be light chain only myeloma. And then abnormal ratios of free light chains can be a precursor for amyloid. So there are diseases where the heavy chain is normal, but there's an abnormal amount of free light chain. And then in monoclonal gammopathy and evaluation of it, the ratio of the free light chains, like the ratio of kappa to lambda free light chains, is important for telling us kind of how worried we should be. So whenever you send an SPEP, I would send along with it a free light chain. Okay, so let's look at our patient's results. So his SPEP came back, SPEP and immunofixation came back showing an IgG kappa M spike with 0.7 grams per deciliter. This is the amount of kappa free light chains. This is the amount of lambda free light chains. They're both within the normal reference range. And this is the ratio, and they're both within the normal reference range. So now we have to decide, is this an MGUS or is this a disease, like a multiple myeloma type disease? And so remember, MGUS is monoclonal gammopathy of undetermined significance. So that means we found a monoclonal gammopathy, but there's no clinical significance that we know of right now. And that is a specific definition. The specific definition is the M spike, so the amount of abnormal protein, has to be less than 3 grams per deciliter. So our patient fits that. They have to have clonal bone marrow plasma cells, so the amount of abnormal clone cells in their marrow from a bone marrow biopsy has to be less than 10%. If it's greater than 10%, that would put you in the smoldering myeloma category until 30%, and then you get the myeloma category. And there has to be no end organ damage. So this is when we think about that CRAB acronym we all learned in med school, which is very hard and confusing for me because many patients have abnormal creatinine, anemia, and hypercalcemia from other reasons. So we have to use our clinical judgment. And I think it's helpful to know that the definitions of end organ damage when looking at monoclonal gammopathy of undetermined significance are quite clear. And I think it's not mild hyperglycemia or mild renal dysfunction. It's really a hypercalcemia greater than 11.5, creatinine greater than 2, anemia with a hemoglobin less than 10, or 2 grams per deciliter below normal, and then bone lesions. So to basically define somebody as having an MGUS, you have to have a bone marrow biopsy and a bone lesion, like, and a bone scan, some kind of imaging to like really say for sure this is an MGUS. But in practice, like, do all patients really need a bone marrow biopsy and imaging? And I know from my practice, like, we don't do this in all patients with suspected MGUS. It would be very cost effective, labor intensive, cause a lot of, an unnecessary sort of testing. And so there is something called the Mayo criteria, which is a criteria for a low risk MGUS. So this is a MGUS that is less likely to progress to disease, like a myeloma or smoldering myeloma. Because remember, about 1% per year of MGUS progresses into disease. So basically, to have a low risk MGUS, you have to meet a couple criteria. This is an algorithm from a great review article, but if your M spike protein is IgG or IgM, IgA is not in this category. IgA is higher risk, and IgD, in fact, is probably highest risk and almost always thought to be myeloma. But if it's an IgG or an IgM, there's a normal free light chain ratio, and the total amount of protein is less than 1.5 grams per deciliter. That's thought to be lower risk. If it is a light chain only MGUS, and the free light chain ratio is less than 8, that's also thought to be lower risk. And then if it's uncomplicated, meaning there's no symptoms we can identify that we think are related to this monoclonal gammopathy, in IgM MGUS, because remember, IgM is a big sticky antibody and it can cause Waldenstrom's macroglobulinemia. We want to think about symptoms of hyperviscosity. So if they're totally asymptomatic, they have an IgG or an IgM MGUS with a normal free light chain ratio, or a light chain only MGUS with a free light chain ratio less than 8, we don't have to get a bone marrow biopsy or a skeletal survey. In everybody else, so if the protein level is greater than 1.5, it's an IgA MGUS, it's a IgD MGUS. Those are folks that are going to need a bone marrow biopsy and a skeletal survey. If you have symptoms you're not sure about, those are folks that are going to need more testing and really referral to hematology. Now, I'll just point out that even in those folks with an IgM MGUS, often it's less likely for those to develop like lytic bone lesions, but we'll leave that to hematology. Okay. And the reason why these folks with a low risk MGUS don't need this further testing with bone marrow biopsy and imaging is because their probability of progression is low. So this is a study that looked at low risk IgG MGUS in particular. And they found that when they did bone marrow biopsies on these folks, only 4.7% had bone marrow plasma cells that were greater than 10%. And only 1.5% of these folks had probable bone lesions on imaging. And probably most importantly, folks with low risk IgG MGUS in particular have a low lifetime risk of progression. So these folks over their lifetime have a risk of only 2% to progress to multiple myeloma. Okay. Now I just want to talk about one more thing, which is free light chains in kidney disease, because this is something that I see often, and I will e-consult, or at the VA, it's called a non-visit consult hematology, and I've kind of figured this out over time, that remember, serum free light chains are cleared by the kidneys. So if somebody has kidney disease and you're trying to figure out, is this kidney disease because of myeloma or because they have hypertension or diabetes or some other cause, you're probably going to see that their serum free light chains are elevated, and that's because they're cleared by the kidneys. And for reasons I don't understand, they both rise, but the kappa levels tend to rise a little bit higher. Like maybe the kidneys have a harder time clearing them, I don't know, than the lambda levels. So when you have kidney disease, you're supposed to use this revised renal reference range for free light chain ratios. So, and in my mind, I just remember when they have kidney disease, the free light chain ratio can go up to 3, and that's okay. So if they have a small amount of IgG protein, they have, say, diabetic kidney disease, and the free light chain ratio is 3, that can still be considered a lower risk MGUS, even though technically the ratio would be read as abnormal. Okay. And then I just want to remind everyone that MGUS increases with age. So as we get older, our likelihood of having a monoclonal gammopathy goes up. And I think it just underlies the importance of being prudent with testing and really figuring out who's lower or higher risk when we get these abnormal SPEPs. So abnormal SPEP, my approach, just to summarize, whenever I'm checking an SPEP, and I didn't talk about the situations in which we check them in this talk just because of time, but whenever I'm checking an SPEP, I always send it with immunofixation, which I don't have to do anything at my institution because it's reflexive, but you should check with yours if that's what happens. I always send it with free light chains and a CBC and a CMP. And I involve hematology often. This is confusing. There's a spectrum of disease. It's a very specialized niche field. And so I refer or e-consult or non-visit consult, whatever it's called in your institution often, except I'm becoming more confident in not referring in these low risk MGUS cases, which again, to reiterate, is an IgG or an IgM with less than 1.5 grams per deciliter, normal free light chain ratio, no symptoms. Okay. Case 3, we'll just do this one quickly. It's a shorter case so that there'll be some time for questions. So JK is a 65-year-old with chronic hepatitis B who presents for an acute care visit for hand pain. The pain is primarily located at the base of his left thumb, though he notices some pain in his right thumb sometimes too. No other joint pain. His pain is worse at the end of the day after playing guitar, and otherwise he feels quite well. On exam, his vitals are relatively unremarkable. He has some mild tenderness to palpation at the left CMC joint. Otherwise, there's no tenderness to palpation in his hands, and you don't note any redness or synovitis. He tells you he's seen for a similar issue at urgent care where he had labs done, but you can't see the results. It's not available. And he was told to follow up with his primary care doctor because his blood test showed he has rheumatoid arthritis. And in this situation, he was told he has a positive rheumatoid factor. So I just want to take the opportunity to remind you that sensitivity and specificity of a test really depend on the population and on the pretest probability. So when we talk about the sensitivity and specificity of rheumatoid factor, it depends in whom we are testing. There was a meta-analysis done that looked at several different articles where they tested sensitivity and specificity and found, like, on average, population-wise, it's thought to be about 69% sensitive and 85% specific for rheumatoid arthritis. But it's much more sensitive when positive in a young, healthy population, meaning folks like less than 40. But in a higher risk, older population with multiple comorbidities, and I'll talk about this in a little bit, when your suspicion for rheumatoid arthritis is low, the positive test is more likely to be a false positive. So I just wanted to show this chart, which shows that rheumatoid factor can be positive in other disease states. And I mean, age greater than 60 is not a disease state, but I just say in other states. So it's thought to be positive in 5 to 25% of people who are just over 60. So being above 60 can sort of be associated with positive rheumatoid factor without any other disease. Endocarditis in particular, hepatitis, and then a number of other diseases listed or conditions can be associated with a positive rheumatoid factor. If you've had multiple immunizations recently or a viral infection, that can cause your rheumatoid factor to be positive. It's important to note that in rheumatoid arthritis, a positive rheumatoid factor may precede the development of the disease for many folks. So that's something to clue into. But people can have a positive rheumatoid factor and not have an inflammatory arthritis or an autoimmune condition. So I just basically all I'm going to say about this is that you need to interpret rheumatoid factor in the appropriate clinical context. In this clinical context, I think it's pretty obvious he had an osteoarthritis at the base of the thumb. He didn't have any other symptoms of autoimmune disease. He's an older gentleman. The pain is worse after use. So probably the rheumatoid factor is a false positive. I'd want to know if other inflammatory markers and anti-CCP were sent, etc. But I've learned over time to be less reactive to a positive rheumatoid factor when I think it's more likely to be a false positive. So I'm wary of them in otherwise asymptomatic older adults. And I think about other diseases. We know in this situation he has chronic hepatitis B. That might be it. Did I do my universal screening for hepatitis C? Did I make sure he's Hep B immune and screen for that? So I need to think about what else could be going on when I see a positive rheumatoid factor. Okay. And those are my references. And then now I'm happy to take any questions.
Give everybody a couple of minutes to put their questions into the chat. Well, I guess while we're waiting, Shada, when you were finding like that the zinc supplementation was contributing to the macrocytosis, did you find like kind of how much zinc did they notice it with?
I did, but I cannot remember off the top of my head. So I can definitely get back to you. It's super physiologic zinc. So it's not like somebody's taking a couple of zinc lozenges because they have a cold kind of thing. It's more people who are really leaning into vitamin supplementation in general and taking mega doses of vitamins.
Okay. First question. Let's see. What do you do for a mildly elevated calcium, especially if elevated on repeat, but the ionized calcium is normal?
Yeah, that's a great question. So in all of my reading and listening to talks on this, if the calcium is mildly elevated, you want to work it up in a similar way you would an abnormal calcium. Otherwise, getting getting an albumin like you did an ionized calcium, getting a PTH to look for hyperparathyroidism, a FOS, a vitamin D, trying to find out if there is a cause for the hypercalcemia. Because if it's mildly elevated, I think it's unlikely to be related to the MGUS. That tends to happen more when it's more significantly elevated. So I would want to sort of rule out the more typical causes of hypercalcemia. Is it a primary, secondary, tertiary? Hyperparathyroidism? Is there a problem with vitamin D? Are they taking high doses of vitamin D? Is there a problem with FOS? And look into that domain before attributing it to a low-level abnormal SPEP. That said, if I can't find anything, like we have lovely hematologists here. They're very kind and nice, but I have a very low threshold to send over an e-consult or a non-visit. If I don't know why the calcium's normal. There's no obvious reason after an initial workup, and they do have an abnormal SPEP.
Everybody another minute or two. Well, I guess I'll just bombard you with my own questions.
Sure.
So I know you had mentioned that it was a little bit out of scope of the talk of kind of the reason for ordering an SPEP. I was wondering though, if while you were doing your research, if you ever did see, whenever we see those elevated total protein levels at like what point that should be triggering us to do a workup and looking for, an SPEP or something abnormal going on there.
Yeah. I mean, I think it's definitely something to consider when you have an elevated total protein, especially when the albumin is normal or low. Typically in myeloma or the spectrum of diseases that myeloma falls on, as the globulin rises, the albumin goes down. Now we know albumin can be low for other reasons like inflammation. It's kind of thought to be like an acute phase reactant, nutritional problems. But if you see the globulin rising and the ratio is abnormal, I think that's a clue. to check an SPEP. I think obviously an unexplained anemia or neuropathy. Those are reasons to check SPEPs. Unexplained renal dysfunction, that's a good reason to check an SPEP. Yeah, but I, I'm often sending him for neuropathy, which turns out to be idiopathic. And then I also find an MGUS, or maybe, there's thought to be this thing, monoclonal gammopathy of neurologic significance. It's just causing a neuropathy, which gets a little bit more complicated. So yeah, if you're seeing an abnormal protein level, in particular, the globulin is elevated or the ratio is abnormal, I would send it. And from my reading, like in the spectrum of tests, an SPEP is a relatively inexpensive and easy test. I think it's just thinking about the can of worms you open with the cascade of testing that comes from it that makes us hesitant to send an SPEP.
Well, hopefully everybody's feeling more comfortable with having to put that SPEP order in, because I think it is definitely, as you're saying, the interpretation of the SPEP, I think, makes us save it as like our very last of the
Yeah.
battery of tests to be done rather than bringing it up to the first like it probably should be.
Yeah, opening the lab result with bated breath. And
All
again,
right.
if you're a little bit confused from today, I highly recommend the Curbsiders podcast. I think it's a really good one. So good episode, SPEP it up. I don't have any like financial link to them. Okay. Well, thank you so much, everybody. I appreciate your time.
All right. So I guess we will take a 10-minute break, and at 11 o'clock we will start our final talk of the pre-course.